So we're live. Welcome everyone to the Patient Safety Leadership Seminar with Professor Ted Baker and Dr. Abdullah Al-Asawi and myself, Helen Hughes. Just absolutely delighted that you're joining us today. I'd like to thank Gov.Connect for all the organising and hosting us, and particularly for BD, who have put in funding to support this series of patient safety seminars. So we're going to have three presentations today. We're going to start with me. I'll try and keep it short, make more time for Ted and Abdullah. And then the plan would be to have a 20-minute sort of discussion panel informed by your questions. And in the chat functionality, please add as many sort of questions, challenges, comments that you'd like to make, and myself and good people that are moderating in the background will keep an eye on the questions to ask. So hello, thanks for everyone. Oh, from Poland. That's brilliant. So I'll start with my session, Leadership for Patient Safety. I'm Chief Exec of Patient Safety Learning. We're an independent charity, a voice for safer care. And I'd like to take you through what I think are some of the key themes for leadership on patient safety. So ultimately, we've known about the challenges around patient safety and avoidable harm since in the UK, Organisation with a Memory was published nearly 20 years ago. And one of the challenges that we think we're raising within patient safety learning is what is it that we're doing that means that the avoidable care, the scale of avoidable care is not reducing in the way that we envisaged those of us that were involved in it 20 years ago. And we think we need to think and act differently about patient safety. And I'm going to explain this.
Hi everyone, it seems that Helen's frozen. I wonder if we could move into Ted's presentation. If you could bring your slides up, and I think Helen's going to rejoin now. Okay, Ted, if you want to begin your presentation now, and I'm sure Helen will join us again.
Well, that was just interesting what Helen was saying. It's a pity that, as ever, with these video presentations, broadband sometimes lets us down. So I look forward to hearing the rest of Helen's presentation soon. I'll just give you my presentation, which I think is very much linked to what Helen was going to say and hopefully will be saying in a few minutes, having seen her slides already. Just to introduce myself, I'm Ted Baker, and I'm Chief Inspector of Hospitals for the Care Quality Commission in England. So what is the Care Quality Commission? The Care Quality Commission is the independent regulator of health and adult social care for England. And we take a view of health and social care in the round, and we look at all parts of health and social care: NHS, adult social care, independent health care, primary medical services, mental health services, and acute services. So in a sense, we have this global view of health and social care in England, and we apply the same principles to how we assess it across the board and how we regulate it across the board, focusing on quality in the round. So we look at all aspects of quality, but of course safety is absolutely at the core of quality, and safety is really something, a very strong focus of ours, as I'll explain as we go through the talk. Now, when we assess services, and I say it's all the services we look at, here we're looking at services in acute trusts, but the same principles would apply for services elsewhere. When we assess services, we ask for 5 key questions of those services. We ask, are they safe? Are they effective? Are they caring? Are they responsive? And are they well led? And we rate each of those characteristics of the services as outstanding, good, requires improvement, or inadequate. And here you see the ratings for all the acute services and acute trusts for 2020 and the comparison 2019. So you can see the change over the last year or so. Now you'll see that many services are providing good quality care. But of the 5 key questions, it is, are services safe, that we most often find problems with. And you'll see that in the top bars on this graph, where you can see that as a percentage of services, 36% of services are either requires improvement or inadequate for safety, and only 1% are outstanding. And so that is a measure of the issues that we want to focus on going forward. And that is why we think not only is safety important in its own right, but it is a priority for us to get right. Now we highlight safety concerns as we find them. And again, I'm focusing on acute trusts here. On the left is a report we published 2 years ago called Opening the Door for Change, which is a report we were asked to do looking at never events in acute trusts. And I think when we were commissioned to do that report, there's an expectation that we'd come up with some process measures to try and reduce the number of never events. To remind you, there are about 500 of these never events every year in England, and the number has not really been going down at all, despite all the initiatives to try and reduce it. The question we are asked is, what more can we do? We started off assuming there would be some technical solutions, checklists, technology, whatever, and we found that those would all be useful. But ultimately, we couldn't change the number of never events unless we tackled the safety culture. And it became very clear to us that safety culture is fundamental to safety. It cannot just be a process-driven approach. You have to get the culture right, and then you have to get the process right. And so safety culture was absolutely key. And some of the things we highlighted in that report, just to detail them, I think the report is going to be on the chat section, so you can download it and read it in detail. But for us at the CQC, it really opened our eyes to this issue of safety culture. And talking to other industries, with other high-risk industries, we learnt that they focus much more on safety culture than healthcare generally does. And healthcare, not just in England, I think internationally in many ways. There was a focus on expertise in safety. So there wasn't an assumption that safety was just common sense, but there was a specific expertise. And we said, one of our recommendations for this report was, we need to focus much more on safety expertise at all levels through the healthcare system. We need to focus on understanding human factors, ergonomics, and team dynamics to see how teams work together. We need to create a culture in which staff can raise safety concerns without fear of retribution. A culture where there's a dynamic conversation about safety every day, where safety protocols are found, where leaders have safety built into their DNA, if you like, so that safety expertise is given to them, but also the focus on safety culture is very much a focus for all leadership. We said that a fundamental change in approach was necessary to achieve the just culture where learning is shared and solutions are created to manage risks. So a fundamental change in culture, we said, was necessary, talking about never events. In the middle are 2 reports, Under Pressure and Patient First, about emergency departments across England. As I'm sure you know, in many parts of the world, emergency departments are under pressure because of increasing demand, and that's something we've been focusing on in England. Last winter was particularly difficult, with a lot of pressure on emergency departments. Before winter, we became under pressure, which you can see there in the middle, which is trying to recommend best practice for emergency departments to keep themselves safe when they're working under pressure. Now, I said at the end of last winter, I was quoted publicly as saying that there needed to be a fundamental shift going forward because we couldn't go on with each winter being worse than the one before because of the pressure on emergency services. That was before we got COVID. And then COVID came in and it became very clear that this winter, the one we're going through at the moment, was going to be particularly difficult because the normal winter pressures would be superimposed with those coming from COVID. And so we worked with departments across the country to produce new guidance called Patient First, there in the middle. And I won't go through this in detail. Again, you can download it and read it. We think it is really very important. And it is guidance from the front line, from clinicians working the front line, to explain how services can best be kept safe when they're working under intense pressure for winter superimposed with COVID. It focused on several aspects: flow through the department, infection control and social distancing, reducing demand for emergency departments where appropriate, making sure you get the best of your staffing, and making sure that patients get the right treatment at the right time when they're in the emergency departments. Very important guidance. And we are, as we approach assessing emergency departments through this winter, we're testing to what extent they are using that guidance to make sure they're keeping safe. On the right is a report we produced in March of this year about maternity safety. And we produced a report because we were concerned that while maternity safety was improving, it wasn't improving fast enough. And we're still seeing too many tragic cases where babies and sometimes mothers have been damaged because of avoidable safety risks that have not been managed. And here we try to draw the lessons of that from our inspections across maternity service in England. And we said 3 things needed to change. There need to be improvements in leadership, culture and governance, coming back to that safety culture again as a core element. There needed to be a focus on competencies of frontline staff, effective multidisciplinary team working and multidisciplinary training. And there had to be active engagement with users of the service. The women using the service should be seen as partners in driving safety rather than seen as passive recipients of safety. And that really was a very fundamental approach which we want to draw into our wider safety culture. And can I just highlight 2 other reports that came out this year, not from the CQC, but from elsewhere. There's a report in the spring of this year around a surgeon called Ian Patterson, who caused an awful lot of harm and for many years in terms of his surgical practice. And there was a report in the summer from Baroness Cumberledge, which was about the concerns that there'd been around a series of interventions in healthcare. And both of them highlighted 2 real factors I'd like to mention. One, there was an issue about culture and the way that services responded when things went wrong. And second, there was a failure to listen to patients and families and listen to their concerns about harm they'd received from care. And I think that is another important element of safety, listening effectively to service users and people who've been affected by care and responding to their concerns appropriately. So where are we now? Well, CQC is responding like all other parts of the health and social care system to the COVID pandemic, and we've changed our approach to a very much a risk-based approach going forward. But I won't go into that in detail now, but I would just make some observations about the response to COVID. We're learning a lot. We've seen some really impressive innovation and leadership in response to COVID. I want to pay credit to that going forward. We've seen an increase in the willingness of people on the front line to speak up about concerns of care. And again, that's something I very much welcome. CQC's seen a big increase in the number of staff whistleblowing to us about concerns about care. And that's been very helpful to us in understanding risks in the system. And I suppose going forward, dealing with some of the safety risks that persist in healthcare, the question is, can we capture some of the innovation and successful leadership during this COVID year and use that to build a more successful approach going forward? So I just want to mention briefly our strategy as an organisation. We put out this discussion document in September about our future strategy as a regulator. And that strategy has 4 themes. People and communities, and that's about looking at services through people's eyes and understanding how they tackle the needs of their communities, particularly health inequalities. Smarter regulation, that's about how we use digital platforms to improve our regulation, but it's also about building a much better relationship with providers, a trusting relationship between us and them, and accelerating improvement, where we recognise we cannot be an improvement organisation because we're a regulator, but we can facilitate improvement organisations or improvement support for providers who have problems. So this is what we said about the 4th theme, safety, or safety through learning. And this highlights some of the themes I brought out from what I've been talking about so far. Focusing on safety culture and the importance of safety culture. An open and honest culture, a culture focused on learning and improvement when things go wrong, and clarity about what a good culture looks like. That's going to be very much central to our regulation going forward. We're going to look to build our own expertise in safety and understand safety better as a regulator, but we're going to expect providers to do that, and providers to provide the leadership at all levels for effective safety. There's a bit of noise on the line, so I don't know if anyone could go on mute who's not on mute at the moment. That'd be helpful. Thanks. We want to make sure that we involve everyone in our safety policy going forward. The frontline professionals, listening to their voice, as I've explained, leaders in the system, but also service users. And I think one of the big challenges we need to accept as a as a system is to involve people who use services, patients and other service users, their families and loved ones as equal partners in safety. As I said about maternity, we don't want patients to be seen as passive recipients of safety anymore. We want them to be seen as partners, equal partners in driving safety forwards. That could be transformative if we do it well. We want to make sure that there's consistent oversight and support, and that means working with all other parts of the system to make sure there's a consistent message about safety. One of the problems we've had in the past is there's often been a fragmented approach to safety. But I think the new thinking about safety, the thinking about safety culture, which I'm talking about here, and which I know colleagues will talk about as well on this webinar, is really important that we are consistent in providing the message that safety culture is absolutely fundamental to driving safety. And as I said, regulating, we want to listen to patients better, we want to listen to frontline staff better and give them the opportunity to speak out about safety issues without fear of retribution. And we want to regulate culture as much as we regulate safety process. So because CQC has a reputation of focusing on fridge temperatures and checklists, well, we want to focus on culture. So we won't say, are you measuring your fridge temperatures? We will say, are you enabling your frontline staff to speak up about safety, and are they confident they'll be heard? We won't say, are you getting your checklist right? We will say, how are you involving your patients in safety actively? And we'll talk about how are you ensuring you learn when things go wrong going forward. So where do we go next? Well, our strategy, which I just highlighted, and the discussion document is available, but the full strategy document will be published in January. Please do look at it, and we welcome your feedback on it. We'll be launching that as a final strategy once we've heard the consultation feedback in May of next year, and then we'll be implementing it. But we recognise that driving safety forward is not something a regulator can do by itself. We need to form partnerships and alliance with every other part of the system. I suppose to some extent my call is for everyone to get involved in this. Safety is too important to allow it to become a fragmented approach. We need to work together to deliver the best safety for people using our services. That's all I'm going to say, Helen, and welcome to see you back. I don't know how much my talk you heard, but back over to you, Helen. You may be on mute, Helen.
Helen, I think you're on mute and you've taken your video off.
It's such a bad day today. I'm on mute. We've had the broadband go down, and I switched my own video off, but not well, honestly. Yes, I think learning from error is something that I'm going to have the opportunity of doing that around my tech support. I'd like to thank my recently graduated history graduate son that came and fixed my tech problem. So the challenge of working from home. Yes, Ted, I heard about half of that, so thank you so much. I think if I briefly do my presentation, and then Noah, you will go back over to Dr. Abdullah Al-Asawi. So I will skip the next slide. We're going to be cross-referring, I think, quite a lot here, Ted. We've in patient safety learning, we wanted to ask and answer the question: why is patient harm a persistent problem? And I think one of the key things that we've identified is that safety is one priority of many, and it needs to be the core purpose of an organisation and a healthcare system. And as you've just said, Ted, safety is too important to be left to certain individuals, whether it's individual clinicians or individual patient safety managers. It's all our responsibility. We also reflected that there are a few safety standards in the way that in other industries, high reliability organisations would have safety standards. And we take standards for granted for looking at issues like fire safety, but not patient safety. We don't always design effectively for safe systems, and permeating our cultures at times are blame and fear, and that absolutely erodes patients' and staff ability to contribute towards safer care. I was going to say this as an introduction to you, Ted. One of the most powerful things that you ever said to me when we met was, until patients are considered to be part of the team, the clinical team, we won't be succeeding as a healthcare system. And it's a comment of yours that's kept, I reflect back on quite a lot in anything we do and that we encourage others to do. And I think for anyone that's working in safety systems, we need to learn from success, but we also need to acknowledge and learn from where things don't go so well, where we didn't plan right, where we got it wrong. But we need to take that learning for action and not just do reports for the sake of it. We really need to make improvements based on that learning. And wrapped around all of this is around the importance of culture and leadership for safety. And I mean system and organizational leadership. So what we've done, if I can move the next slide, Rob. If you could move it on. Yes. So what we've described in our blueprint for action, which you all have access to because it'll be on the offers page, on the resources page of the webinar slide deck, is if we were going to design for safety and not just address harm, what is it we need to do? And we've described in there, and you can see in the report itself, almost the flip side of our learning about why harm is persistent. And underpinning it all at the very bottom is a just culture, making sure that we're in a psychologically safe place to be able to enable all those initiatives that we need. If you could move the next slide, Rob. And I knew that Ted was going to be focusing particularly on culture, and I think Dr. Abdullah will the same about culture and as part of a safety movement. But I just wanted to reflect here where we invest our time around safety and patient and staff safety. And this is something from industry and from our human factors and ergonomics colleagues, and looking at where the best bang for your buck is. If you are going to make improvements around safety, where do you spend your time? And I think healthcare more broadly, not just in this country, but just generally as a healthcare system, we've invested a lot of effort in improving safety in probably the least effective methods for doing that. So if you look at this slide, and it shows from other industries where you're looking at a system, how you can make improvements and what brings sustainable change. And they are about forcing functions, stopping bad things happen, and they can be kind of physical design improvements, about automation and computerization. So many safety incidents are around clinicians not having the right information at the right time and addressing those and communication issues, simplifying and standardizing how we work. And what we know, they have their place. All of these have their place. But if we just focus on checklists or double checks or reminders, remember to be careful, rules and policies in documents that sit on a shelf, and training courses that remind people to be safer, those are the ones where often we've made investment, but we haven't had the sustainable change that comes from a system-focused approach. So we think more needs to be done to move from people-focused to system-focused, and that's not recognising the embedding of culture, but some of the tools to make those improvements. Next slide, please. And so just a little bit about patient safety learning and what we've been doing, and particularly during this pandemic. So our priorities are using our evidence-based research to call for action to improve safety. So we speak truth to power as a charity, and we can reinforce the voices of many to influence policy and government, but particularly to share learning and resources. And I'll come back to how we're doing that. We work directly with staff and patients, very much about frontline engagement with clinicians and with patients, campaigning for safety, collaborating. As Ted said, it's all about partnerships and alliances, aligning the whole healthcare system and social care system for safety system improvement. So we've been focusing on our Blueprint for Action foundations. We've supported some of the initiatives and campaigns around during the COVID pandemic. And particularly would like to focus on, I haven't got time to go through some of the specific campaigns around safety, like pain-free hysteroscopy in the context of Cumberledge, but I'd like to focus on just quickly on 3 areas: staff safety, our knowledge sharing platform, the hub, and what we're doing on standards and accreditation as our offer as a partner for patient safety. Next slide. So what we focused on, World Patient Safety Day this year in September, was rightly focused on health worker safety and the idea that patient safety and staff safety are 2 sides of the same coin. And I think my personal reflection is that in the world of patient safety, we've kind of rather taken staff safety for granted. And clearly early stages of the pandemic really brought into hard focus the necessity of having physical safety for staff as a core part of our overall safety agenda. But not just the adequacy of PPE and minimising the risk of infection, but avoiding staff burnout with overstretched staff. It's not good for them, it's not good for motivation. We have 40,000 nurses vacancies in the NHS. That could be much compounded by staff being overstretched and exhausted. But if you're overstretched and exhausted, you make mistakes. You're in an error-provoking environment that will potentially lead to unsafe care. And the psychological safety, the culture change is absolutely imperative for staff needing to feel safe about speaking out, about identifying opportunities for improvement, and for staff being supported when things do go wrong. If they're responded to with blame and intimidation, people will not feel secure and they won't learn, and organisations won't be able to take the action they need to prevent future harm. Next slide. So one of our contributions, and the URL details are in the pack here, is our online platform for patient safety. It's been designed, it's a free repository of knowledge. It's ideas, stories, tools, case studies, research, good practice, communities of discussion, news and stories. And it was deliberately designed for everyone. So to break the hierarchy between people, to encourage a partnership about shared learning. And it was designed with clinicians, by patient safety experts, patients, regulators, system regulators like CQC, and professional regulators. And if you go onto the next slide, you'll have a few little snippets of in our just over a first year since we launched. So we've had over 300,000, now we've had nearly 300,000 page views, nearly 120,000 people have visited us from 174 countries. The membership we have, anyone can use it. You don't have to become a member, but it is free to be a member. But if you look at the members here, it is what we hoped it would be, which is a resource for patients, for safety leaders, for industry suppliers, for regulators. And we have over 4,000 knowledge resources and communities that are discussing campaigns, and particularly patient and frontline staff campaigns. So we very much hope that all of you that are on the call will be able to join in and participate and share and create a global knowledge repository and resource for safer care, patient and staff safety. So we've taken a little longer with them because of COVID, but we're at the final stage of quality assurance, and we'll be we'll be sharing these for people to benefit from the early part of next calendar year. And we've created, based on our blueprint for action and all the evidence base that is within that, we've created 7 foundations with 26 standards underneath it that have evidence-based outputs. And it absolutely isn't a tick box exercise. It's around behaviours and actions and providing people with insights as to how to aspire to standards and then deliver against those. And that we're planning also to have an accreditation framework that would celebrate people's achievement on that, but would have an evidence-based assessment that would against 3 levels. Which would align, we hope, very much with system and professional regulators, so that organisations can assess and set goals for safety performance, and staff, patients and communities and regulators could be assured at the organised focus in delivering transformational change for safety. Next slide. And that's what you're not going to read that because it's too detailed, but it's that kind of rigor that we've developed, that with this one was on leadership and governance, but we've got a number of key priorities within that, defined standards, what outputs you would expect to look for, and what were the evident behaviours and actions would be to achieve that at whatever level. Next slide. So we hope that some of the resources that are on the hub, the sharing of knowledge, the contribution through our campaigning, but also through the development of the standards and the accreditation framework, will provide more tools and resources. So we know why we need to change, why we need to make improvements. We know what we need to do. We want to actively engage with all partners to help with the how to make it happen. And so that I'm going to conclude my introduction and now invite you, Dr. Abdullah Al-Asawi, to do your discussion. Dr. Abdullah and I have known each other only a relatively few months. We met online and we met in person in February in London and then in Geneva. And I don't want to steal your thunder, but if patient safety becomes a global social movement, then this man will have been an important part of setting that going. So it happened here. I'm over to you.
Thank you very much, Helen, and two brilliant presentations by you and Ted. So I'll try to keep up. Let me start with a story. So I think we've heard very good, background of what happened in patient safety over the past couple of decades, why it is a problem. But let me just share with you a story that can kind of put this in perspective. So in 2007, someone who's a famous actor, I think most of us know Dennis Quaid. So he and his wife had two twins, a baby boy and a baby girl. And they were at one of the top hospitals in the United States. And, this is a public record story. So it is Cedars-Sinai Hospital. And, these are the twins of Dennis Quaid. So unfortunately, they went through a horrifying ordeal where they received 1,000 times the dose of heparin. And heparin is a blood thinner for non-medical people. Not only once, twice. And unfortunately, the same time, a third baby also received the same mistake. 1,000 times the blood thinner twice. So this is basically changing your blood from regular thickness blood into almost water. Fortunately, they did not end up dying, but you can imagine the ordeal that the parents went through. Now, there's a little bit of echo in the background. If you could mute yourself, I think that would be helpful. So if this could happen to someone like Dennis Quaid in one of the top hospitals in the United States. This could happen to anyone. Unfortunately, since 2007, and if you fast forward, 13 years, how many heparin overdose mistakes took place throughout the United States and throughout the globe? Endless. And the issue is, so why is it that when we know what to do, we're still, keep doing the same mistakes? So believe me, harm does not, basically distinguish or differentiate or discriminate between whether you're a man or a woman, you're a famous person or an average person, whether you live in Europe, North America, Africa, or in the Middle East or Asia. Harm does not discriminate. And just to give you a little bit of statistics for the countries that did the studies. So in the United States in 2016, a study in the BMJ journal found out that 251,000 Americans die from medical errors. And that was the third leading cause of death in a country like the United States, only preceded by cardiac and cancer. And in 2018, another study in Canada also found out that almost 28,000 Canadians die from medical errors. Again, it was found to be the third leading cause of death, preceded by cardiac and cancer. Now, Jeremy Hunt, back on the 2019 in the fourth Global Ministerial Summit in Jeddah, Saudi Arabia, he talked about during his time as a Minister of Health in the UK, every week 150 people in the UK died from preventable harm. So this is the equivalent of an airplane crashing every week. Now, if you compare us in healthcare to other high reliability industries like aviation, do you think any public anywhere in the world would put up with an airplane crashing every week? This is 52 planes crashing a year. It took only 2 planes, 737 MAX 8 that, crashed within 8 months apart, one in Indonesian Airlines and the other one was in Ethiopian Airlines, to ground every 737 MAX 8 throughout the globe. Only 2 planes crashing. And you talk about, compare this to healthcare, where we just take this for granted. And the question is, how long are we, how many people are we going to basically watch getting harmed, and how many more preventable deaths are we going to watch before we stop and say, enough is enough? I'm going to talk to you about 3 industries that have actually said enough is enough. So aviation, back in the 70s, 5-6 decades ago, aviation was not as safe as it is today. And it took that famous crash between the 747 in a Spanish airport for the aviation industry to say, enough is enough. For the nuclear industry, it took Chernobyl to actually, say enough is enough. And for the oil and gas, also, another major accident took place that got them to say enough is enough. The question is, how many more stories like Dennis Quaid twins are we going to have in healthcare before, we say enough is enough? We think almost up to 5 million people lose their lives from medical errors. That in low middle income countries, the studies have shown that 2.6 million people die from preventable harm. This is the equivalent of 5 people dying every minute. So that's just low middle income countries. Every year, 11 million people die from sepsis. Most sepsis is preventable. So why is it that over the past 2-3 decades, we've managed to bridge the knowledge gap So, and I think even the last 4 or 5 years have seen a lot of improvement in the activities and the momentum to improve patient safety, starting off with the UK's leadership in establishing the Global Ministerial Summit on Patient Safety during the time of Jeremy Hunt in 2016. I was lucky enough to attend all the the previous 4. One in the UK in 2016, Germany in 2017, Japan in 2018, and I was basically honored to lead the organizing committee for the 2019 in Jeddah, Saudi Arabia, which focused on patient safety in low and middle income countries. So, and lately we put patient safety on the G20 agenda during the Saudi presidency. And when we discussed patient safety in the G20, we looked at 5 reasons why we think that the implementation gap continues to exist. And I think both Ted and Helen have kind of addressed those. So culture is safety culture in healthcare compared to the safety culture in aviation and nuclear industry is, let me just put it this way, there's a big room for improvement. My brother is a pilot. He flies in Saudi Airlines, and sometimes I'm just, ashamed to talk to him about the situation of the safety culture in healthcare compared to the safety culture in aviation. So safety in aviation is religion. Safety in oil and gas is religion. Safety in nuclear is religion. Unfortunately, we still have a long way to move towards, any kind of resemblance or similarity with those industries. So safety culture is one. Global advocacy, and one of my goals, for my next chapter, and I was honored to lead the Saudi Patient Safety Center in Saudi Arabia from establishing it in March 2017 until October 2020. Where I stepped down to chase my next, moonshot, which is establishing a global fund for patient safety and health workers' safety, and hopefully, by 2021, this fund will see the light of day, which will be the one of the tools for implementation. But part of the difficulties we've seen is when you compare, just do this exercise with your loved ones, and at home. Just ask your family members, how many of you is aware of the global climate change? I think most likely every hand will go up. And I think out of the 170 people watching us now, I think every hand will go up. And I think if you ask the same 10 people about how many are aware of patient safety or understand what patient safety is, unfortunately, you're not going to get the same number of hands going up, and that is just telling about the huge gap between the understanding of the average person of the patient safety, the preventable harm, and these huge, horrendous numbers. Again, death is the tip of the iceberg. The 2.6 million people dying in low middle income countries. This is the tip of the iceberg. You can multiply by hundreds to basically get the whole picture of the people that are being harmed but not losing their lives, but they could lose an organ, they could lose a function, or they could, even if they're just emotionally harmed. Put yourself in the shoes of the Kuwaits when they had their babies almost die from totally preventable, medication error that unfortunately exists today, I think, in every country on the globe. So again, when is the time for us to say enough is enough? Like, it is one thing to make a mistake, but why do we keep making the same mistakes over and over again? So the second is a global advocacy, and my goal is for us to create a global social movement around patient safety that is as vibrant and as active as the global climate change. And believe me, this is not, just me being, dreaming. I think if we look at the compare global climate change and global patient safety, I truly believe that both are extremely important. But I don't see global climate change being transformed in my lifetime, but I truly believe that the global patient safety challenge can be transformed and can be seen in our lifetime. It is just something that we have to do more job trying to reach out to the average person and make it mainstream. Patient safety has been concentrated within very small groups of people, the academia, the quality people. We have to push it mainstream in two directions. One, for the public, and the other is to push it mainstream even for frontliners, clinicians. Many of the clinicians actually do not even grasp, the gravity and the magnitude of the problem. And everyone thinks, oh, this doesn't happen to me. This doesn't happen to my patients, until it does. So the second is a global advocacy. The third and the fourth is something that the global, the patient safety learning hub is working on. One is the information asymmetry. So in many industries, you don't have that huge gap between a service provider or a product provider versus, when you look at healthcare, there's a huge gap between the information that I know as a physician compared to the information that the patient and family knows just across, the examining table or the bed from where I talk to them. And unless we do something to bridge that gap, and unless we do something to really empower patients and families on a regular basis, we will continue to have challenges. There's a concept called co-production, which is if we want to reach a high quality and safe care, we cannot do it alone as providers. We have to co-produce this high quality and safe care by both the provider side as well as the patients and families and the community. So I'm a big advocate of any initiative that could push for more empowerment, and we really have to kind of integrate the co-production into every day-to-day workings that we do. So not just to kind of engage patients here and there. This has to be, part of the norm of everything that we do. The co-design, the co-delivery, the co-assessment, all the different parts of the co-production. And the other thing is also sharing learning. And for us to share learning, we have to have the common language. Well, even though that the WHO came up with something called ICD, which is International Classification of Disease, we don't have an ICAE, which is something that we asked for in the Jeddah Declaration in 2019, which is to have an international classification of adverse events. So how can we learn? Sometimes even the same department within the same hospital goes through the same mistake, and the right hand is not talking to the left hand. So, it would be even a dream or maybe kind of just something that is not going to happen anytime soon for us to learn between hospitals within the same city, within the same country, and then, globally and worldwide. And for us to be able to do that, we have to be using the same language. So basically the last one, out of the 5 reasons and 5 causes, if I may, for the the persistence of the implementation gap is the lack of resilience. And again, Helen brought it up, and I think even Ted brought it up. We have to have human factors engineering and ergonomics into the the fabric of the care provision, and both at the micro level and at the macro level. And other industries that have transformed safety does it. We don't, and I think this is also something that unless we do, we're not going to be able to really transform safety. So I'm going to stop here. You know, as I mentioned, you know, there has been lots of you know, initiatives, and the momentum is picking up for the global patient safety movement. But I think there's a lot of work that needs to be done, and I'm always optimistic to think that we will get there. You know, such an event, you know, the people that are with us in the event, you know, one person could get excited about this, and he or she could really help, you know, get us into another level and push towards, you know, another dimension. So again, thank you very much. Happy to have any discussions during the Q&A.
Helen, you're on mute
still.
So sorry, you wouldn't have heard, you wouldn't have been able to see the questions and comments that were coming in thick and fast. I sort of picked them up when Ted was talking, and we've got several hours worth of discussion, and we don't have that time available. I would like to draw on the theme of co-production and patient engagement as the kickstart. So first question to Ted, really, in light of what Dr. Abdullah said, and I know that's a core part of your professional and personal focus on safety around patient engagement and delivering safer care. Any reflections back to Dr. Abdullah on what he was saying and his impassioned plea for that co-production?
Yeah, absolutely. I agree with everything you said. You know, so thank you very much for that contribution. It really was fascinating, and it does reflect the fact that the issues we're talking about are not local issues; they're international issues, and they're a reflection of the culture of healthcare across the world. And that is the ambition we're trying to do. We're not trying to make a small difference locally. We're trying to change the culture of healthcare across the world. And you know, that is a huge ambition, but equally it is a vital ambition if we're going to deal with some of the harm that does occur every day. And you were talking about you know, jets, airplanes crashing, and of course, you know, airplanes only crash occasionally, and when they crash, there's a big investigation, and there's learning, and everyone says that will not change again. The trouble with healthcare is adverse events, preventable harm is occurring every day, 24 hours a day, every day. So it's kind of been normalized. There's a normal expectation preventable harm will occur. We need to move on from that and accept the fact it is not, we can't accept it. So preventable harm is, we know it happens, but we should never find it acceptable. And we need to do that in a way that doesn't create a sense of blame or recrimination about it, because we all know we're fallible. And I think this is one of the great problems. And you talked about doctors, you know, not realizing that the risk until they actually see the harm themselves. And I think insightful doctors are good at this, and they recognize the risks they live with every day. And I think the doctor who doesn't recognize the risks is really the worrying doctor. When I was medical director of a big hospital, it was always the consultants who were not worried about, you know, safety that worried me. Not the ones who were very confident were always the worrying ones. I remember one surgeon I had enormous respect for told me one day, look, I'm only as good as my next mistake, you know, and you know, and I suppose that is one of the problems we live with, is that doctors and other frontline healthcare workers live with a daily sense of jeopardy, thinking that if I make a mistake, the world is going to be very unforgiving. And yet they know they're fallible, so they know mistakes will occur. And we need to move on from that. We need to move on. We need to accept that everyone is fallible, accept mistakes will occur, but equally accept we've got to learn from those mistakes to try and reduce them happening in the future. And I think that will free up people. We hear a lot about burnout as an issue amongst healthcare professionals at the moment. And I think we're creating a culture of jeopardy, everyday jeopardy, that makes their working lives much more difficult. And actually, if we can take that jeopardy away from them in the sense of, actually, we recognize you're fallible, we're going to support you not to make mistakes, and we're not going to blame you when you do, we can change the environment in which they work. And that in itself will help. So this question of fundamental change, I think, is really important. And just to come back to the issue of co-production, absolutely. We've got to move on from this paternalistic culture where, you know, the professionals know best and the patients just do as they're told. We've got to involve the patients, understand the risk, and help us make the service as safe as we can. And I think that is a real opportunity. And that kind of diversity of opinion we'll get from patients, that challenge to our culture we get from patients, will be only for the good, and we need to value it.
Thank you. And Dr. Adder, reflecting on those, you talk about patient safety as a movement, and whether we can reflect on what's happening on culture change, and that our friends and our families will understand climate change, but they won't understand the scale of unsafe care. And it's the kind of it's the biggest secret that's in plain sight. There's a quote which is a very odd quote to give, which is a quote from Stalin. And he talked about one death is a tragedy, but 1 million deaths is a statistic. And I would reflect back on what Ted says, is that we've kind of normalized our approach to unsafe care and avoidable harm, and we've just kind of accepted it. Can you say a little, Abdullah, about how you, in working both nationally within Saudi, but now globally with the G20, how you think global leaders can contribute to sort of exposing the scale of this and encouraging healthcare systems around the world to attend to it as a core purpose?
Absolutely. So why am I excited about making the comparison between the global climate change and patient safety? I think they're both extremely important, and I'm a big believer of both, and I think many people do support the global climate change. Now, if you look at the declaration from the G20 here in this year, the Saudi presidency, you're going to be very surprised to see the language around climate change. So this is the presidency here in Saudi Arabia, which is a big oil and gas producer, but the global climate change movement have pushed on governments, on key stakeholders. And so many of those were pulled into this kicking and screaming, but it became a reality. And I think reaching that critical mass have helped it. And I'm afraid to say that there is an anti-climate change lobby that exists for different reasons. Now, patient safety is different. I have yet to find any person anywhere in the globe that wants to be harmed or wants their family to be harmed. I have yet to find any clinician that, unless he or she is basically, having psychological issues to harm patients, that are for harm. So this is what I'm trying to say, is this is a much easier story to communicate, that we could have common ground, between us here in Saudi and you in the UK and in Brazil and in North America and in Asia, because it's a human story, that when you talk about preventable harm, when you talk about first do no harm, this is something that everyone could communicate with. So what we need to do is we need to personalize and redefine patient safety, not as the absence of harm in general, and redefine zero harm not as, zero harm cannot be reached, which I'm totally against. Every time that a patient deals with healthcare is an opportunity for zero harm. So we can have a zero harm for one shift. We can have a zero harm for one day, and we can celebrate that. But the way to do it is we have to bring patients and families on board. I absolutely second, Ted's, point about paternalistic approach. We just cannot. We can't. It's not even just that we want. We can't. We've been doing this for the past 20 years, and believe me, why is it that we're still where we are? Because we decided that over the past 20 years that this is something that we have to do alone, and we ended up in burnout, and we ended up read about the second victim, and how people actually take their own lives feeling guilty about their patients getting harmed. But if we look at this as a complementary approach, where at the time of admission, at the time of patients engaging with us, we would say that, we're not perfect. We can't, but we can, if we look at this as a partnership and a co-production, then we can actually do much better. And patients and families would actually feel responsible about their own safety. And it's interesting, when I was actually talking about the concept of co-production in one of the meetings here in Saudi, one of the patient advocates who actually was on the receiving end of a medical error, he said something very interesting. He said, if you involve me and actually, either in an informed consent or in whatever care provision, then not only that I'm going to help you, but even if something happened, I'm not going to hold you accountable, because now we're looking at this as a partnership. So that's another angle that we're missing. So I think that the patient empowerment is absolutely critical, and I would believe that also human factors engineering and ergonomics, integrating that will create resilience.
Thank you. I've just asked Rob from Gov.Connect whether we've got a hard stop at 3. He's allowing us to roll forward a little bit. I don't know, Ted and Abdullah, whether you've got another 10 minutes or so to stay on, because there's just so much to talk about, and many more questions. I've got one which is a very tangible, quite practical one, where obviously reflecting that the three of us have emphasised around culture change and organisational culture change. And someone, I've lost the name of the person that's raised the question, but saying actually culture change tools, culture assessment tools and culture programmes can be quite expensive. And they're reflecting that each individual organisation is kind of encouraged to develop them themselves. Is there an opportunity, and I think this is probably more for Ted, but Abdullah, you might want to comment, that within the NHS there's an opportunity for there to be resources that could be available to everyone, so not everyone's having to reinvent the wheel on this really important kind of issue, but what are the tools and resources that people would have available to help them make this journey? I don't know if you've got reflections on that.
Yes, I think measuring culture is a useful part of this. There is I suppose, if you look at the leaders of healthcare, do they ask themselves every day, what is the safety culture like in the people I lead? They should be doing that. I've been to working in healthcare for many years, I've been to so many meetings where we've discussed the financial bottom line. Are we working within budget? Important, because the budget is there to support the provision of care, but actually there should be equal focus on what's the safety culture like here today. How are we doing? What can we do to improve it? How can we make sure that safety is to the fore? I think the issue about resources, yes, we clearly need to find ways of resourcing this, but ultimately healthcare spends out so much on its mistakes that safety ultimately will drive saving of finances. One of the things that I found really inspiring going around and talking to hospitals, you go to hospitals sometimes that have real problems, and usually the ones that have got poor health quality problems often got financial problems as well. And it takes a very brave leader to say, I'm going to deal with the quality problems first and the financial problems will sort themselves out. But actually, that is what has happened. And talking to some inspirational leaders who've tackled quality in their organisation, they've tackled safety. And at the same time, they've found that they've saved a phenomenal amount of resource going forward. And they have staff who are, if you like, they have fundamental problems such as recruiting staff. It's much easier if they create a high-quality environment for those staff to work in. So I think if you tackle quality first, other problems that seem insurmountable at the moment can be resolved. That's not to say that we shouldn't be trying to seek resources for safety wherever we can, but ultimately safety is about driving high quality care that is likely to be more efficient and more economical in the long run.
And I know, Dr. Abdullah, that will be music to your ears, and you might just, in the few moments we have left, you might want to reflect why you commissioned as part of the G20 work, the OECD updating their work on the economic case for safety and the business case, because I think that aligns very well with what Ted said. You know, the unsafe care, avoidable harm costs a huge amount of money. Let's redirect it and invest for safety. Do you want to let the participants know a little bit about your passion and commitment on that issue?
Absolutely. So one of the discussions that we also had in the G20 about the fact that when a citizen is harmed, the country loses twice. So not only that you lose that person as a revenue generating individual to the GDP, but he or she will become a burden on the system because you have to treat them. So that's the whole idea of the economics of patient safety, and I think this is a very important angle that we have to keep pushing forward if we want to engage policymakers and politicians about the money, because when you talk money, I think they governments listen, and again, COVID 1.3, maybe within a year we'll end up with 1.4, 1.5 max million people dying. Only in low middle income countries, 2.6 million people die from adverse events and preventable harm. And we've talked about the other numbers in other countries. So up to 5 million people lose their lives from preventable harm. I mentioned sepsis, around 11 million people lose their lives. So why is it that we're just focused on that? And don't get me wrong, I'm for all the engagement that happened in dealing with COVID to some extent. Now, what about the more people that die from other? Is there a better way to that you need to avoid to die, or is it like a death is a death is a death? And not to mention. I call this the overlooked pandemic, and I call sepsis the overlooked pandemic, because this is just going to, as you said, Helen, it's kind of hiding in plain sight. So again, having said all that, I'm very optimistic. I think the fact that Italy now is keeping patient safety in the G20 agenda for 2021. And hopefully, that will continue even for the Indian presidency in 2022. Hopefully, we can see also patient safety on the G7 agenda in the UK's presidency. I've mentioned the Global Fund initiative that we're working on lately, and this is something that I lately also have been working on, which is to launch a podcast about patient safety. We're calling it Vision Zero, and that's going to hopefully go live in early 2021. And the whole point is to try to engage. The concept is basically to push patient safety for mainstream. I think between the three of us, we're believing it's an echo chamber. So we believe in everything. How can we push it to the mainstream? And I think the only way that we can transform safety is if we can get more and more people to believe that this is something that is important, and if we can get more and more politicians and decision makers to believe that it's important. And I think when we do that, I'm not going to say if we do that. I think when we do that, we will transform safety. So I'm going to end on a positive note.
And actually, I think that I've got a couple more questions, but realistically, we've just run out of time. I think that is an incredibly positive note. And the final reflection national agenda. This is about the transformation of healthcare for safer care and for staff safety through being psychologically safe. So it's not just, you know, many of the people on this call will be from the NHS, but these are issues that are being grappled with internationally. And just final thank you. Well, thank you to GovConnect and BD for facilitating and enabling this to happen, but particularly Ted and Abdullah, an absolutely amazing webinar. We could have carried on for hours. Maybe we'll come back and do another one. That's all I'm saying. But fantastic. And for now, thank you very much. And thanks to everyone for joining in. Bye.
Yeah. Bye.